I have been warning you and maybe making you a little bit afraid because I told you time and time again, it's approximately twice as much material, and we're not going to have twice as much time unless we want to make twice as much time. So I said it'll be a little more fast and furious. We're starting it early, and we'll be continuing it completely into this island session, so that will help buffer things. Plus, you're used to the basic body language and the words of pathology and the concepts, because we've been over them so many times. So hopefully we could do this a little bit faster. But if we do it too fast, you're not going to be happy, and I'm not going to be happy. If I do it really fast, and you have read a lot, maybe that would be another little factor. But I don't like to go so fast that I feel I'm neglecting you either. Nevertheless, what I decided to do today is try to do that entire pretty good sized chapter in one day. Maybe I can do it, maybe I can't. I'm going to sort of try. I'm going to take a little poll at the end of the session to see if it was too fast, or if I think it was too fast, we'll just have to slow down. Also, remember, we have all of the Robbins chapters, the 7th edition online. It's not linked through my websites because I don't want publishers suing me. But as you know, when you go to my website, if you just add ch11.pdf or .htm, you'll get the exact chapter in PDF or hypertext form, respectively. We'll be doing the last approximately 20 chapters, which is 11 through 29. Systemic pathology is more interesting to most people. Maybe if you like the concepts of pathology to begin with, that's nice. But this is going to be more clinical. In other words, when you go to grand rounds or various presentations now for the rest of your life, they will always be reviewing the concepts that we're going to be talking about today for many, many, many years, no matter how medicine progresses. Most likely in 10 or 20 years from now, if you go to a conference, a case presentation or a grand rounds on carcinoma of the thyroid, they'll be going into the same basic concepts we're going to be talking about when we get to the endocrine chapter. So I just wanted to tell you, I personally like the last, or Pathology 2, better than Pathology 1. I like Pathology 1, but I like this better. There's a lot more material. I am assuming everybody is more or less in the classroom. Let me take a look. Yeah, it looks like we have a big bunch there. If not, you could go there now. And let's start Pathology 2. Here are our first 10 chapters here. So we start with 11. It's called vessels or blood vessels. And if you remember, we deal with blood vessels and contents in 3 different chapters. We've already dealt with the flow problems and thrombosis problems associated with blood vessels. Now we're going to look at the vessels themselves, and we're going to be spending a couple of chapters on the cells that flow in the vessels as well. So there's all kinds of ways to look at blood vessels. And the best way I like to look at a blood vessel is the simplest way, and I hope you can see. It's basically a straw. It's a pipe. It's a conduit. It has a hole in the center, and it has a wall, and the hole in the blood vessel is called a lumen. Now, from basic histology, if you remember, whether you're in the heart, whether you're in the aorta or it's any of its major thoracic branches, the so-called elastic arteries, or whether you're in a huge artery, or whether you're in a medium artery or an arteriole, or a metarteriole, or a precapillary arteriole, or a capillary, or a vein. No matter where you could possibly be in the body, if you're flowing around in if you're a blood cell, you have to be in direct contact with a single endothelial cell. So here in the northwest, you could see an elastic artery, perhaps in the aorta, That single endothelial cell is number one. And then you can see a bunch of elastic fibers throughout its wall. Here you can see a classic arteriole where the elastic is the internal elastic lamina in a wavy fashion. This is in the northeast now. But still, look, that single endothelial cell, and sometimes you can see the nucleus. Then you can see the smooth muscle. And if it's a really, really big artery, there might be a few scattered elastic fibers, depending on if that artery has to sustain a good systolic, diastolic pulse difference. Here's a classical neurovascular bundle here in the Southwest. And once again, remember, a lot of times even experienced people have a hard time differentiating arteries from veins. The general and best rule is in a artery, the media or the smooth muscle always arranged with axially with respect to the axis of the vessel is thicker than the connective tissue of the adventitia. And in a vein, it's the opposite. You have more connective tissue in the adventitia than you do in the media. And that's why even the very, very hugest veins of the body, like, the inferior vena cava, they only have just a few layers of smooth muscle cells. Here's fat surrounding it too, and there's a little nerve there. And last but not least, you could probably think of a capillary as nothing but an endothelial cell that's big enough to squeeze a blood vessel through. And so remember, no matter where you are, you should always think of intima, media, and adventitia. Of course, for the capillary, I got to think of as that one endothelial cell. And also in a artery, don't just think intima, but think of an internal elastic lamina. What you see here is a squiggly little band, as well as some often and usually an external elastic lamina, but most of the artery is just plain old smooth muscle, except for the really, really big arteries, which are called elastic arteries, like the aorta and the branches of the thoracic aorta, which are loaded with elastic fibers. So this is what we just said. The components of all blood vessels. They'll be talking about having diseases today: intima, media, adventitia. We said media is bigger than adventitia in an artery, and A is bigger than M in a vein. Everything has endothelium. The arteries have internal elastic lamina, usually an external one as well. And don't forget, the extracellular matrix distributed throughout the blood vessel. And remember, blood vessels are connective tissue, aren't they? They're not epithelial tissue, because as with all connective tissue, you have a wide variety of substances between the fibers. And of course, a smooth muscle cell is also called a smooth muscle fiber. You have loose connective tissue around it. You have fat. This is the general architecture of blood vessels. And the thing I want you to remember, this is why I really thought hard about how I could present blood vessels, because blood vessels are basically straws. From a functional point of view, no matter what disease we talk about today, you can only have two basic things go wrong to interfere with the function of that vessel. You could have either narrowing or blockage of its lumen, and we talked about thromboses and all the factors, or you could have rupture of its wall. And the rupture is usually preceded by weakening, and the blockage is usually preceded by narrowing. So from a functional point of view, no matter how we're going to go into all these little weird classifications today, possibly, from a simple functional point of view, the blood vessel is malfunctioned when it's narrowed, blocked, weakened, or ruptured. And here's the topics we're going to talk about. In every pathology chapter I've ever seen, there's always two topics to a discussion of blood vessels. There's atherosclerosis, and there's everything else. Because atherosclerosis is the biggest killer. Usually about half of this material, probably the first half today, will be primarily on atherosclerosis and nonspecific injuries. Then the rest of it, everything else. So we talk about vascular wall responses, nonspecific to injury. We'll talk about a few congenital anomalies. We'll talk about that big thing called atherosclerosis and how it's different from arteriosclerosis generically. We'll talk about the role of hypertension as both a cause and effect of arterial disease. We're going to talk about aneurysms or dilatations and weakenings of the wall. We're going to talk about the vasculitides, or the things that inflame the walls of blood vessels, whether they're specific agents or they don't have external pathogens, which would make them sort of autoimmune. We'll talk about a phenomenon, not a disease, called Raynaud. We'll go a little bit into veins, lymphatics, tumors, and interventions. Let's do some definitions. Arteriosclerosis is hardening of an artery due to any cause. Atherosclerosis is hardening and disease of arteries due to the deposition of atheromas, which we will be talking about. Aneurysms are bulging of arteries. They could be false if it's only a thickened wall that makes it bulge, or they could be true aneurysms if the entire lumen is also dilated. Dissection means things like blood, in fact, almost exclusively blood, hemorrhage has been occurring within the wall of that artery, causing it to weaken. Thrombus, we've already defined. A blood clot occurs. Hypertension, increased pressure, usually arterial, but you can also have increased venous hypertension, can't you? Like in congestive heart failure. A vasculitis is also called a vasculitity, and that's at either a specific infectious or non-infectious inflammatory condition of the wall of the artery. Most of them are non-infectious, and because we defined autoimmune diseases as situations in which there is inflammation not from specific pathogens, external, but autoantigens. That's basically most of the non-infectious vasculitides are autoimmune. Varicosity is a weakening, a bulging, a tortuosity on the vein side of the circulatory system. We already talked about deep vein thrombosis. For all practical purpose, that's exactly the same as thrombophlebitis. For all practical purposes, that's the same as the concept of phlebothrombosis. Clinically, this condition is most often just called DVT. Sometimes it's called thrombophlebitis. And very rarely is it called phlebothrombosis, but it's the same thing. More definitions. We talked about arteries and veins. If a lymph vessel is filled with inflammatory cells, perhaps it's blocked because it's packed so much, or perhaps it's just draining a lot of inflammatory cells. That's a lymphadenitis. Lymphedema is edema due to usually blockage of a lymphatic vessel. Angiomas and hemangiomas are generally generic names for benign tumors of blood vessels. A lymphangioma is a generic name for a benign tumor of lymph vessels. Angiosarcoma, generic general name for a malignant tumor of blood vessels. Why? Because it has the word sarcoma in it, which means, you know, blood vessels got to be connective tissue or mesodermally derived. Lymphangiosarcomas, technically, is the generic name for malignant tumors of lymphatics. Okay. Let's talk about the non-specific vascular wall responses to injury. Now, first of all, I know exactly what you're going to think. You're going to think, hey, this guy Minarsik is double dealing here, because he's describing all of these non-specific responses. And then when he talks about atherosclerosis, I'm going to sound like I'm repeating it. And that's really the truth, because the processes that we will see a little bit later in atherosclerosis very, very often mimic the so-called non-specific response to injury. That means perhaps atherosclerosis can be thought of as being not a very specific disease, but a disease due to several risk factors. And indeed, that's the reason. So these are the four non-specific vascular wall responses. Well, as you might guess, we already talked 3 or 4 times about the endothelial cells being Jekyll and Hyde. If you leave them alone, they do everything in the world to keep the blood from clotting. If you activate them by a whole wide variety of anatomic and physiologic stimuli, they are the main troublemakers in arterial diseases as well, and venous diseases, and blood vessel diseases, and thrombosis. We're going to talk about the role of smooth muscle cells. We normally think of those as being sort of boring, but in nonspecific responses, as well as atherosclerosis, they multiply, they disrupt the internal elastic lamina. They go to places they shouldn't go to. And of course, when we talked about inflammation and repair in general, we talked about how blood vessels remodel, grow, and the single most uniform, nonspecific vascular wall response to injury is intimal thickening. It's also one of the earliest signs in atherosclerosis as well. But now we're talking about nonspecific vascular wall. You remember in the vascular smooth muscle, remember? It's ranged generally circularly or axially with respect to the axis of the blood vessel. So when a vascular smooth muscle cell or fiber constricts, the blood vessel constricts. When it dilates, the blood vessel dilates. That's a simple geometric fact. You know that the vascular smooth muscle also makes the extracellular matrix. So if you thought that fibroblasts were the only thing that makes collagen, I got news for you. The smooth muscle cells do it too. However, you can also have fibroblasts in a blood vessel wall as well. The smooth muscle also makes the elastin, the proteoglycans, or ground substance. And as you might guess, there's a wide variety of things that can promote vascular smooth muscle to constrict, like platelet-derived growth factor, a substance called endothelin, which is released from the endothelium and is one of the first things to cause those smooth muscle things to constrict. Thrombin also. And of course, things like heparan, not heparin, but heparan sulfate, nitrous oxide, and transforming growth factor beta are the big inhibitors of vascular smooth muscle. So this is kind of a generic statement, but one of the four things we have to consider when you talk about blood vessel growth and remodeling, you're talking about, this is a direct quote, the sum total of all factors and processes involved in tissue injury by which vessels develop new pathways and reperfuse areas. Well, we talked about extensively in the chapter on remodeling, didn't we? So this is not new. So let's take a look at this little diagram here and we'll look at some non-specific findings. Remember we said that intimal thickening was the thing that is the universal event. Well, if you look at the very left side, you see the normal blood vessel. You can see your endothelial cells lined up nicely. If it's an artery, you see the internal elastic lamina. Doesn't stain well on H&E. It looks bright and squiggly, but on elastic stains, it stands out like a bullet that looks so good. Then you have your smooth muscle cells. Well, in injuries, these smooth muscle cells can migrate through the elastic lamina, disrupt it. And in the case here now, for example, they can divide as well. Remember, cardiac muscle cells don't divide, striated muscle cells don't divide, but smooth muscle cells divide. And remember, we said that these smooth muscle cells, or vascular smooth muscle cells, also elaborate the extracellular matrix. So this is the reason for intimal thickening, isn't it? It's because of migration, multiplication, and elaborations of substances by smooth muscle cells. Okay, now that we've defined the general responses, let's get rid of this quick and easy topic of congenital anomalies. Now, I want to tell you that the general organization for all of the systemic pathology chapters will be a general discussion on normal anatomy, histology, physiology, and then it goes into the classical types of diseases. Remember, we said degenerative, inflammatory, neoplastic. So usually tumors of lung would be at the end of the lung chapter. Tumors of the kidney would be at the end of the kidney chapter. But there's always this introduction of congenital anomalies or congenital diseases. And congenital makes me feel a little nervous because when I kind of told you flat out that anatomically speaking, there's only three kinds of diseases: degenerative, inflammatory, and neoplastic, I kind of ignored congenital because congenital doesn't quite fit in. That's the bad news. The good news is that clinically speaking, there's only one main type of congenital anomaly, and they're called arteriovenous fistulas. They are also called arteriovenous malformations. It's exactly the same term. The radiologists and the cool people like to call them AVMs. And what it is an problem in the development of a blood vessel embryologically where there is an abnormal connection between the arterial and the venous side of the circulation. So because of that, there may be some hemorrhage involved. There may be some thickening of the venous end. And the one thing that is universal is that there is a lot of twisting of the blood vessels too. This is usually a congenital problem. In other words, happens before they're born. But it could technically sometimes be acquired if there is some trauma or inflammation to that blood vessel as well. And of course, you know, if you say to a radiologist, you know, did you ever see an AVM? He's probably going to assume you're going to be talking about the brain, although technically they could be anywhere the arteries and veins are. And most AVMs statistically are asymptomatic, but they could hemorrhage. And if they're area like a brain, they could hemorrhage, they could be fatal. So here's an AVM of the brain. Normally, you should only see, here is a without contrast and with contrast. Without contrast, you could see that there appears to be something kind of crossing the midline and it kind of distorts the general texture between the gray and the white matter. And here, with contrast, in which you're seeing the blood vessels much better, you can see that these blood vessels are twisted. They might form a mass effect. And this could be, believe it or not, something this big in a brain could very well be asymptomatic, but it could also rupture or even non-rupture and be fatal. And technically, if you were a good enough dissector to dissect out these vessels, all they would be a twisted nest between arteries and veins. And it would be so twisted, you couldn't really tell histologically what was the artery or what was the vein because they just look like twisted vessels with thick walls. That's all. Now, you know we're going to have to lead into our big topic this morning of atherosclerosis. So let's get some basic definitions. Arteriosclerosis is anything which hardens an artery. And 99% of arteriosclerosis is at the process we will be defining as atherosclerosis. So that's why, even though it's not technically correct, atherosclerosis is almost always used synonymously with arteriosclerosis. But now you're learning better. There's a condition called Monkenberg's medial calcific sclerosis. It is not atherosclerosis. It results in the media or the muscle part of the artery becoming calcified. Nobody knows exactly what causes it. Technically, that would not be atherosclerosis, but that would be a form of arteriosclerosis. Another thing to remember is that often they'll use the term arteriolosclerosis, especially in the kidneys, but other places, to define hardening of the small arteries and arterioles. And very often, this may not be classically part of atherosclerosis either. Make a long story short, if you use the term atherosclerosis and arteriosclerosis interchangeably, nobody would ever nail you to the wall for it. Here's classical atherosclerosis. It's a disease. And here is the 4 common features to all diseases, which we learned on day 1. Etiology, or risk factors, the sequence of cellular events that goes on in the development of the disease or pathogenesis, what it looks like in an X-ray, grossly, microscopically, And also the clinical expression. What kind of symptoms do the patients have? This is the classical thing you would like to think we're going to do with atherosclerosis. Robbins, however, has a little bit of a modification. They're going to be talking about natural history, epidemiology, risk factors, pathogenesis, other factors, effects, and prevention. This is pretty much the same as our classic four, but we're going to have to live with the fact that they've modified it a little bit. So what's the natural history of atherosclerosis? Well, this is really a great chart, and I don't know where I got it from, maybe Robbins. And there's different ways of looking at it. You know, in the old days when I was a student, they said there's 3 facets to atherosclerosis. We do the autopsies on various people. If you could only see a little yellow streak along the inside of the artery, you can't feel it, you can only see it. That's a fatty streak. It's yellow because you have cholesterol there, and maybe some monocytes now have gone in through the endothelium to become macrophages, and they're chewing it up. Then there's a part you could feel, which was called the atheroma. This is a plaque. It may be calcified, it may be thick. It may occupy a significant portion of the lumen as well, but it's usually not symptomatic. When it becomes thrombosed, which is what happens in infarcts, including myocardial infarcts, you have both severe atherosclerosis and thrombosis. Then the vessel becomes non-functional. It could infarct the area that it supplies if there is not much collateral circulation. And it could be downright very, very symptomatic. It could be fatal. That's the easy way of looking at. You can also look at it from a more splitting sort of thing, from type 1, which are isolated foam cells, type 2, where you actually could see them now grossly, type 3, you could see some extracellular lipid microscopically. 4 now is our atheroma. 5 is a fibroatheroma, in which you have a fibrous reaction to the whole process, a lot of calcium, more likely to have calcium. And 6, a very complicated severe lesion. This is just 6 ways of describing the same thing we did there in 3. And here are other things we could divide them into. For example, fatty streaks in most atheromas are clinically silent. Thrombi can not only be clinically overt, but they could be fatal. Also look at the age. The thing you have to know, kids get atherosclerosis, teenagers, even younger than that. That's where it starts. It's a lifelong process. Here's the same thing from a little more graphic point of view. You see a normal artery. You can see a fatty streak, which is yellow, but you can't really feel it. When it becomes bumpy, because of more intimal thickening, you could feel it. Up here, you have something advanced, compromises a lumen. The wall can actually weaken because of this whole process and rupture, and the person could literally bleed to death, or more likely bleed into the wall, forming a thickening of the wall, false aneurysm. Or if the whole lumen is dilated, a true aneurysm, it could occlude. And then it could also restenose, or what they call recanalization. Even after a blood vessel is completely occluded, you could have new blood vessels going into the thrombus to recanalize it. These are all possibilities. So let's look at some of these terms. We've already opened the door and defined most of them, but let's remember that these common terms that you'll be using when you describe your patients on rounds, some of them are more microscopic pathologic terms, but intimal thickening is the beginning, more or less. Lipid accumulation makes the streak go more into a plaque. And the streak is just something you see, you don't feel. Atheroma is something you could feel, also maybe calcified. Further, more progression of diseases is more infiltration of those smooth muscle cells to lay down more substance. They could become secondarily fibrotic. It could calcify. Most of them do. You know, most of the severe atherosclerotic vessels are calcified. If the blood vessel wall is further weakened, it could be dilated. And if there is a secondary thrombosis in that atherosclerotic area, then this is the classic cause of an infarct anywhere. So here, let's go through this again. We're going to be mentioning this about 10 times when we're in the other chapter. You need two things for a heart attack. Let's call it a heart attack. Let's be real simple. Let's call it an infarct. You need both atherosclerosis and you need a secondary thrombosis on top of that. That's how it happens. It's not likely to get a thrombosis in a normal artery, and it's very, very risky for a severely atherosclerotic artery to be a trigger for thrombosis. Here's the fatty streak. You can see these little yellow blotches. Here's another way of looking at it to enhance them. And look here, this is the key thing to remember from this. Even though this aorta looks kind of good, and if you're in an anatomy lab, you could probably snap your friend with it because it'll be like a rubber band. There's still these little yellow things. And look they tend to occur now around the openings of the mesenteric vessels. What does that mean? What does that tell you? What it tells you, if you remember from your physiology, there are pressure increases of blood pressure around the opening or the branchings of arteries. So what does that tell you? It tells you that atherosclerosis starts in areas of increased pressure. So all of a sudden you could see the relationship between hypertension and atherosclerosis. They are intimately related with each other. Hypertension causes atherosclerosis, like you see here, because that's where the yellow early plaques, streaks begin. And secondarily, once there's severe atherosclerosis and that artery is no more rubbery, you then have hypertension as well, don't you? And those are concepts that are both really easy to understand. Here's your plaque again. Let's look at the context of a plaque. There's either disruption or pushing down of the internal elastic lamina, which are these blue box cars. You can see that the smooth muscle cells have already migrated. They have laid down some ground substance. There's lipids, cholesterol accumulation. Here are the foamy histiocytes that are chewing up the cholesterol esters. Here are some fibroblasts. Grossly, it would look yellow. Microscopically, if there was calcium, you would see blue. And look at, what else do you have here? You see this little blood vessel here and here? Well, look, remember, this is an inflammatory process, remember? And remember, part of inflammation, you have ingrowth of new blood vessels, various things secreting vascular endothelial. So there are more blood vessels inside of this blood vessel. If you remember from your anatomy and your histology that the vasa vasorum of arteries are clearly and chiefly towards the adventitia and external parts of the artery, here we have a case where you're having ingrowth of new blood vessels near the luminal end. And also notice that for the most part, even though this plaque looks kind of nasty, as always, if you really carefully examine it, there's still in the blood vessel interface a nice lining of endothelial cells.
May I ask a question, please?
I'm sorry, do we have a question?
Yes, sir.
I'm hearing a lot of buzzing, by the way.
Well, I'll make it quick. Do taking drugs such as Crestor or Lipitor decrease those accumulations of lipid in the intima?
Okay, you want my opinion?
Yes.
I'll give it my best shot. The answer is no. What it does is lower cholesterol, so there's no further accumulation. The topic of reverse atherosclerosis has been around longer than we've been alive. And there have sometimes been some evidence of atheromatous lesions regressing. But for the most part, the therapy, like the therapy of cancer, is not to make everything go away, but to keep it from advancing, including things like Alzheimer's disease. That's the general quick answer. Here are some mild plaques in the aorta. You can see some segmental arteries here opening. You can see some mild plaques. You could get the feeling that this is not just a yellow discoloration. In advanced, there's more calcium. The plaques are bigger. They may be ulcerated. That's why you get that red or brownish stuff there. There's hemorrhage into them. And this is really, to tell you the truth, for your and my age group, this is, this is probably not on the left here. Could very well be what we all have right now. I don't think it would be pretty grisly to say some of us might have this, but it's possible because these could still be asymptomatic, except you would know, for example, that if this was ulcerated and hemorrhage, had a little bit of thrombus on it, that person would be showering little arterial emboli throughout his body, wouldn't he? Let's look at the general clinical features of advanced atherosclerosis. We mentioned it, but if the artery wall is weakened enough, it can rupture. If the plaque protrudes into the lumen enough, you can have disruption of the endothelium with ulceration, secondary hemorrhage, or I guess ulceration and erosion can pretty much be used interchangeably. We talked about some of those little thrombi forming in the ulcerated areas, becoming atheroemboli. And the difference between the atheroemboli and let's say a venous emboli is that if you had something that lodged downstream and it had a little cholesterol cleft in it, that would have to be from an artery, not a vein. We talked about hemorrhage. We talked about thrombosis. And we talked about enough weakening of the wall to cause it to bulge into an aneurysm. Here's a few little features to review microscopically. I don't think we'll have to go into this a great deal. I think you recognize the L as being a lumen. I think you can recognize C as being the cholesterol or fatty part of a plaque. I think when you see something that blue, which you see over here, that looks a little bit flaky, I think that that's probably going to be some calcium. I think if you do a trichrome stain like you have here and you see a lot of green or greenish blue, that that's going to be fibrous tissue. I think if you do an elastic stain and you see this nice black squiggly thing along the external part of the artery, that's the external elastic lamina. You're having a hard time finding an internal one, aren't you? And so on and so forth. The one, you may also see, for example, here, cells that are foamy, and you could probably call those foamy macrophages. If you see like a blood vessel here in the northeast within the plaque, you could call that neovascularization. So the concept we introduced conceptually and clinically, we are now looking at microscopically. Okay, let's talk about the disease. What causes it? Well, we don't know what causes it, but we do know there are 4 risk factors. We know that it's generally related to the development of a nation. The rich nations, rich foods, high cholesterol, great risk factors for atherosclerosis. U.S. is about the highest. There's generally been a significant decrease in death, though, probably because of the stuff they do to foods as well as advances in more of a knowledge of it. We know that it's generally a disease of, clinically, we all know it starts in childhood, but we all know that when it develops clinical symptoms like infarcts, they're generally older people. We know that women are protected for about 10 years relative to men because there has been the so-called protection effect of estrogen. So if a man, let's say, has a fatal heart attack, let's say 50s or 60s are good age, or maybe even 40s, but women generally don't have clinical atherosclerosis until after menopause. Of course, as you would guess, being a multi-genic thing, you can't pinpoint one gene, but you should also guess if there's a family history of it, you're going to get it because of this multiple gene principle. These are the 4 major risk factors. Don't ever let anybody tell you there is anything but these 4. If they do, they're full of baloney. They've been watching too much television, or maybe they should win a Nobel Prize. I don't know. These are the 4 risk factors. Hyperlipidemia due to any cause. Hypertension due to any cause. Cigarette smoking and diabetes. when they did this massive Framingham studies and all the other studies after that, this is what turned out as being the major risk factors. You could also divide the risk factors into things like modifiable and non-modifiable, major and minor. And of course, anything that's not major has to be minor. And there's only four major things like you see down here. And look at, they're all modifiable, aren't they? You could modify your blood cholesterol. You could take, Lipitor. You could treat hypertension. You could treat diabetes. You could quit smoking. So isn't it interesting? Besides genes, almost all the major risk factors of atherosclerosis are modifiable. You can't modify your age. You can't modify the fact that you're a male and you're more at risk. You don't have that premenopausal protection like women do. You can't modify your family history. But look, here's a whole bunch of other minor ones. Obesity, physical inactivity, stress, the type A personality, postmenopausal estrogen deficiency. Remember, we talked about this in chapter 9. A high carb intake, alcohol. Didn't those jerks tell us that a little bit of alcohol is good for your heart? Baloney. Trans fat intake is a minor risk factor. And also, we're going to talk about the role of a few viruses that might have something to do with it and other pathogens like chlamydia. These are all minor risk factors. You might want to remember them. You can see that most of them are modifiable. You can see almost all of the classical major risk factors are modifiable. But the things you can't change are your age, your sex, your family history, or your genes. Okay, there we are again. Always know those. Let's talk about hyperlipidemia, the first one. Chiefly cholesterol, but also the high-density lipoproteins. And of course, as we all know, if we watch TV, from the last 20 years, that HDL is our good stuff and LDL is our bad stuff. It's because the HDL actually mobilizes the cholesterol away from the plaque and into the liver. So a low cholesterol diet is good. Unsaturated fatty acids are good. These are all going to help your hyperlipidemia, prevent it. The omega-3 stuff is good. If I didn't believe it, I wouldn't be taking a fish oil pill every day. And exercise is very good too, not just in general, but it also has a lowering effect on cholesterol and a positive effect on HDL. Here's the cholesterol in the plaque. So doesn't it stand to reasonable that the more cholesterol you have in your blood, the more is going to be causing these needle-shaped fatty crystals in your plaque? And another little tip is really, I know you still maybe feel a little bit weak at histopathology, but when you see these needle-shaped clear spaces inside of a plaque, it can only be cholesterol. Or what I really mean are cholesterol esters for the most part. It can't be anything else. Okay. Dolores is okay now. Let's look at some more statistics. I can't remember where this is from, but we're going to talk about 10-year risk of ischemic heart disease, heart attacks, with respect to other factors. So look how the blood pressure has a direct relationship. Somebody with a systolic of 120 is about 1/5 as likely to get ischemic heart disease as somebody at 160. And that's only a 20-point difference. Look at the cholesterol levels. You're only going from 220 to 260. Look at the big difference. The HDL, the opposite effect. When it's low, the risk is higher. And then we're only talking about between a 50 and a 35% difference. The presence of diabetes, very, very big. That's basically an all on or off situation. And of course, cigarettes, either you smoke or you don't. If you do, these are all things which really increase your risk. You could quantitate them. All kinds of studies have been done. Let's talk about the hypertension part. We already knew that if in areas of the artery where there's increased pressure, the atheromas develop. So what does that mean? It means hypertension causes atherosclerosis, doesn't it? On the other hand, if you have seen or felt in anatomy lab or anywhere else, uh, arteries that are severely atherosclerotic, they're like nails. They're not rubbery anymore, you know, so they're firm. And what happens if you have a pipe that doesn't bend? It means there's going to be increased pressure inside there. So it's a cause and effect relationship both ways. Hypertension causes atherosclerosis, and atherosclerosis causes hypertension. I'm not going to say anything more about cigarettes, the other one of four big risk factors. You know, all the heart surgeons, and I know this for a fact, they tell their patients when their patients ask them, well, you know, what caused the heart attack or why does this guy need the surgery? And they'll say two things, genes and cigarettes. Okay. So cigarettes are as big a factor as diabetes. It's really bad. And the sad thing is it's 100% controllable, isn't it? Diabetes can be controlled. And I want to say a little thing about diabetes. We'll be spending a couple of days on it in the future. But if you study diabetes your whole life, like I have, and I also have a touch of it, by the way, and probably some of you will too, is that if you really look at what happens in diabetes, the more you study diabetes and the more you study atherosclerosis, the more you have to conclude that they're probably the same disease. Now, I know what you're thinking. You're thinking, wait a minute, diabetes is due to bad islets and, you know, atherosclerosis is due to too much cholesterol. They're different diseases. Well, when you look at the expressions of diseases from a pathologist's point of view, the damages to the arteries, the more you study it, the more you have to conclude that possibly the same disease looked at it in different ways. I know that's a pretty bold statement to say that, but always have a bet with my students. If they could prove to me that they're totally different diseases, I'll give them an A for the course. So far, they haven't been able to do it. Okay, is everybody, by the way, this is a good time. It's 9:55. I still want to do a few more slides, but this is a good time to ask if, type in quickly if you're hearing me well. I sense you are. I heard a little bit of buzzing there, but I want to have a whole bunch of people say yes. Okay, I hear it.
We lost Chuck for a little bit, but we got him back on. So maybe
Great,
that's it. Maybe the
great.
buzz.
Okay, let's look at the next thing, which are a few of non-major risk factors that you'll hear about. For example, homocystinuria. It's related to a low B6 and folic intake. It'll result as homocysteine in the urine and elevated in the blood. That is a complicated factor, but it's not a major factor. Of course, somebody with a coagulation defect is going to be hypercoagulation is going to be another major risk factor. We talked about that in the previous chapter. A lipoprotein LPA, if you have that in your blood, you have a risk factor. I'm not going to go into the physiology of that, but even things like really type A personality, you're always hyper, you're always nervous, you don't exercise enough, obesity, and this is even if it's independent of diabetes. They're all non-major risk factors. And once again, I don't want to have to go on my soapbox, but if somebody ever tells you if you drink a little, that's good for your heart, if you believe that, you know, then there's a really, really nice bridge that's in Brooklyn, and I would like to sell it to you. So here we go. What causes atherosclerosis? Well, we know a whole bunch of risk factors, don't we? Minor and major, modifiable and non-modifiable. But what causes it? And unfortunately, still, even though it's been the biggest killer, we don't know, but we can say this for sure. This is a very, very, very important quote from Robbins. Atherosclerosis is a chronic inflammatory response of the arterial wall initiated by injury to the endothelium.
You have an
Now, I know
incoming
what you're
call from
thinking.
Dolores Watt.
You're thinking, well, Minarsik told us that atherosclerosis is a degenerative disease, and now he's telling us an inflammatory disease. Well, what that proves is that there really is no clear-cut separation with a lot of processes. They can also find that certain endothelial cells are clonal in atherosclerosis. So does that mean it's a tumor? Well, it's the mother of all diseases because when you really study it, you see it have features of all of the three aspects of pathology. Um, I want you to remember this, just like you remember the inflammatory saga. I want you to remember this. We've already been talking about it. I want you to remember the pathogenesis saga. Chronic endothelial injury, like we just saw. Buildup of cholesterol, esters, low density cholesterol, oxidation of lipoproteins. At that point, the monocytes come in to chew up the stuff. And remember, that's what causes the fatty streak. So we already have three things going on here before you even see the fatty streak, don't you? And then, so before you see the actual yellow streak, you got things going on like endothelial injury, accumulation of cholesterol, oxidation of lipoproteins, more inflammatory reaction with platelets, migration of smooth muscles, laying down some more substance, foam cells, and more accumulation of lipids in the intracellular, extracellular matrix. This is a generally good linear thing to remember. I would love to give you a test where I gave you these things and say, okay, put them in order. Let's look at the next one. I hope we can look at the next one. This is the same thing we just said, and I want you to remember it graphically also. The chronic endothelial injury due to a variety of possible things, including a few viruses like CMV, chlamydia, toxins, smoking, okay? Number two, the endothelial dysfunction, the increased permeability, the monocytes coming in, becoming foamy by chewing up all the junk, the smooth cell migration. This is linear. This is how it happens step by step. Then further enlargements by more macrophages and smooth muscle cells engulfing the lipid, maybe lipid pools, maybe calcium. This is the 5-step process. I think it's easier to remember this than the other one, but you have to remember the correct appearance of characters in this saga. Okay? If you wanted to narrow it down to 4 things, you could look at it this way: endothelial injury, inflammation, accumulation of lipids, migration of smooth muscle cells, and laying down some more of the matrix. These are all processes that occur, and they're in the correct order as well. Are you getting kind of tired of this? I am too, because we're basically saying the same thing. On the left side, here's your normal wall. Here's some accumulation of lipids. Here's the macrophages coming in to chew it up. Here's the smooth muscle cells migrating next. And here's accumulation, some more, maybe some neovascularization. And this is atherosclerosis. I love this diagram the best. Okay, guess what? We're almost done with it. Remember we said that this is one disease where you could tie in inflammation, neoplasm, and degeneration all in one. Well, we think of atherosclerosis as degeneration because the arteries are degenerating in older age. They're not working. They're accumulating all this junk. But there have been studies to show that the cells in the plaque are oligoclonal. And remember, we said if a cell is clonal, it could be the result of a neoplastic transformation, not necessarily malignant. So that is the neoplastic arm of the theory of atherosclerosis. In addition, it has been showed that chlamydia and CMV, remember CMV was in the herpes virus family, are very, very common injurers of endothelial cells. So that can also trigger off the process. So here we go at the bottom. Look at my little lecture note: degeneration, neoplasm, inflammation link, all considerations in this disease we call atherosclerosis. What are the prevention principles? We've already mentioned: know what's preventable, know what's minor, know what's major, know primary and secondary principles, understand it begins in childhood, and like everything else, the sooner you start the preventive measures, the disease will be. And even somebody asked a question about things like statins and stuff like that. For the most part, I mean, I know a lot of people would disagree with this, but let's be practical. The treatment of the disease when it becomes asymptomatic is not so much to make it go away, but it's to keep it from getting worse. And even though I could probably show you a few little studies that show there's some kind of mild evidence for reverse atherosclerosis, but for the most part, don't rely on that happening too much during your lifetime. Last slide is the fact what we'll be discussing in the next hour. We've already done half the chapter. I think it's been a good pace. So now we'll do the second and last part when we come back in 10 minutes, and it'll be what we call everything else. We're half done, folks. See you in 10 minutes. Margaret,